So, hi everyone, it's Nina Collins from The Wolfer, and I'm here today with Danielle Spencer, who's the academic director of the Columbia University Master's Program in Narrative Medicine, which is a program I did. I did it in 2013 to 2015, and Danielle was there, and Danielle was my professor in at least one class, maybe two, and I'm pretty sure she gave me an A. I think I got one A minus in that program. It could have been Danielle, I don't remember, but anyway, Danielle's great, and I thought that it would be interesting to have a conversation about narrative medicine because people are often really curious about what it is, and so welcome and thank you.
Well, thank you, Nina. It's really great to be here and great to have the chance to connect. And just so everybody knows, Nina was a star student. And I have a particular memory of the time when you brought Muffin to class, who added so much to our discussion. And it's been really inspirational to so many people in our community to see what you've done, starting this amazing organization in the years since. So I was really looking forward to this conversation.
Oh, thank you. That's so sweet. Yeah, it was a really special experience. I guess we should start by telling people, like, what's your elevator speech on what is narrative medicine?
Yeah, so it's sort of twofold. I think that the field began as it was very oriented toward clinicians as a way to help to train clinicians to be more patient-centered, but specifically in the way to be more attentive to and have more tools to understand, unpack, and honor the stories, patient stories of their experiences. And so Rita Sharon, who's one of the founders, there's a group of people from different fields who came together. Rita Sharon, Sayantani Dasgupta, Morris Spiegel, Craig Irvine, philosopher, pediatrician, literary critic, so forth. And Rita is an internist, and she also got a PhD in literature. And so that initial orientation had to do with helping clinicians to take these narrative tools so that they could better serve their patients. So that's still there. It's still one of our core mandates, and narrative medicine is really is deployed a lot in medical schools and other healthcare professions contexts, and that's actually kind of accelerating. But in addition to that, the field is really inclusive and it welcomes people. Anybody who has a body who's interested in these questions is welcome to join this conversation. And the field is also thinking about questions of inclusivity when it comes to illness narratives, to people being able to think about and write about and express their own experiences of having a body, especially when it comes to illness and disability.
That's great. So, because one of the jokes when I was in the program, I think when I did the program, it was only maybe 3 years old. And it was super interesting because I always say, like, about half the students, and I wonder what's changed. I'd be very curious to hear. About half the students were young kids who were just out of college and planning to go to medical school. And they were doing this to kind of pad their resume, but in a genuine way. Like, you found that everyone in the program, pretty much everyone, had been marked by some sort of really distinctive personal tragedy or story. Like, there was a reason people were interested in this program. So you had all these, like, kind of half the crew were like medical students who, were interested in death and dying. And then the other half were kind of people like me, like mid-career lawyers, writers, journalists, you get the occasional nurse, people who for various reasons were interested in this. And when I did it, so my interest really was because my mom had died when I was 19 of breast cancer that she had kept a secret. And I had been kind of plagued my whole adult life with that trauma. And I think I really just wanted I wanted to go to graduate school. I'd wanted for a while to get an advanced degree. And I thought about therapy and I thought about going to law school. And then I stumbled upon this program and it just so spoke to me, even though it seemed completely impractical and was quite impractical. But I think I was really craving a legitimate way to study death and dying and to kind of understand more what my mom had gone through and maybe allay my own fears. And I don't know, I was just really drawn to it. So when I give the elevator speech, and everyone's was different at the time, you would say to people, how do you describe what we're doing? And everyone had a slightly different thing. And I always say it's the study, I just wrote it down to remind myself, the study of how we tell our stories in the context of death and dying. And then you kind of elaborate. And to Danielle's point about it being, because I ended up actually working for a couple of years, really practicing narrative medicine at a hospital. And And I found that there was a lot of interest when I was in the program. There was sometimes talk is like, is this for patients or is it for clinicians? And I did get a job working, training clinicians. So it was all around communication and healthcare, basically. So I'm curious how the program has changed in the last 5 years. And it does seem like there's more of a field now. Like I see like the Schwartz rounds. One of the students, Stephanie, is doing these Schwartz rounds, which is so great. Like there are a lot of people actually doing real jobs out there, which must be satisfying.
Yes, it's really an interesting time for the field, and it's sort of intersecting with all the challenges that we face in healthcare and society. So it's changing quite rapidly. So the field, yeah, so the program, this is a master's program, and it's just entering its second decade, so it's still quite young. But now there is, I mean, we have a total of almost 300 graduates, and a bunch of them are clinicians. I mean, I graduated from the program, and a bunch of my classmates are now clinicians, and some of them are engaged in bringing narrative medicine into the training programs that they're involved with, and some of them talk about how their training in narrative medicine influences the way that they practice medicine or nursing or physical therapy or whatever the case may be. And I think that's still, I think we're skewing a little younger. Every year we do have a big, I don't know the exact percentage, but maybe half of our students are either heading off to healthcare profession school, or they're taking a year in between, medical school and residency or something. But one of the strengths of the field is kind of like bioethics, is it's intrinsically interdisciplinary. So having people coming in from various different fields and life experiences, and then heading off to do different things. So yeah, I think that's very exciting. Yes, Stephanie Adler-Yuan is now helping, she's running the programming in the Schwartz Center, which is a wonderful program.
It's amazing. When I was at Maimonides, I ran our Schwartz Center round. So it's
a
perfect. Yeah, I did. It's an amazing program. So it's super cool she's working with them. I love that.
Yeah, it's very allied. I mean, I think there are a lot of different allied approaches toward, trying to humanize healthcare that are called slightly different things. And for me, I don't really fuss about the details. I mean, if you want to call, whatever you want to call it, we share so many goals, So narrative, yeah.
And you're right bringing up bioethics, because when I worked at Maimonides, I also sat on the bioethics committee. And I mean, they're completely intertwined, right? Narrative medicine and bioethics. And so, yeah, I think your point is really true. There are so many directions you can take it. Maybe it would be interesting, I think, probably for our listeners, for you to tell us a little bit about what the program is exactly. I sometimes have a harder time explaining what we learn there and how it's taught. Like my favorite class was definitely the death and dying class that Marcia taught, that I took my first semester. I loved all my classes, but that was a great class. But yeah, can you tell us a little bit about the program and what do you teach now?
Yeah, well, so our core courses, the ones that are required for all students, include a course called Close Reading, Giving and Receiving Accounts of Self, exploring relationality through literature and film. It's a little bit more on the academic side, but also bringing in, how you're responding to text individually and as a group. There's a course called Self and Other, which is also exploring relationality, but through philosophy. And we have many students who've never studied philosophy before, and so it's designed to accommodate them as well. And then there's a course in creative writing, which is absolutely wonderful. My colleague Nellie Herman is the core faculty member. She's a novelist.
She was my advisor.
Yeah. Illness and disability narratives. It was, of course, originally designed by Saintani Dasgupta, wonderful, amazing scholar, activist, writer. She teaches that course. And there's a course in qualitative research. And then beyond that, then there are a bunch of electives that people can choose from. So the death and dying course is one. I teach a course called Narrative Ethics, which is going back to, sort of bringing in bioethics, but looking at ethical issues through the lens of contemporary, like a lot of contemporary film. So actually like watching an X-Men movie and talking about, surprisingly, how it's a really interesting way to start to unpack issues of disability.
Really interesting.
Yeah. But that's just, obviously I'm going to hawk mine first. No, but
No, no, but we want to hear. And I mean, it is so, because what's so interesting about the program, right? So for people who are listening, you'll notice there are a bunch of classes. I mean, there's a creative writing class. I read, in fact, I named What Would Virginia Woolf Do? The predecessor to the Wolfer, right? Our original name was inspired in part because of a class I took that I think Danielle taught, right? Didn't you teach it, co-taught it with Maura, where we read To the Lighthouse very, 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 very closely. In fact, I had to write a 20-page paper on, I think the assignment was like a paragraph of text or 2 lines of text. So there are all these ideas around close reading, and
Yeah.
you talk about film a lot and kind of paying attention to relationality in film and text. So can you explain how that correlates to medicine, to healthcare?
Yeah, so this goes back to the original idea, sort of like the core idea of the field, which is to draw a connection between the act of listening to a patient, clinician listening to a patient, should have the same skills as that of a reader, an attentive reader to a text or a spectator to a film, so that the close reading and close listening have so much overlap. And so taking a step away from the clinical context and saying, all right, well, what happens when we spend a whole semester reading Virginia Woolf? This is a course that was designed by Rita Sharon and Maura Spiegel, and very, very slowly and carefully going through and close reading. Well, what happens? The text, I mean, this is infinitely rich text, and you're doing it with your colleagues. The text starts to unfold, and you're bringing in, so in our program, it's a master's program, so we're bringing in some learning about concepts from literary theory and criticism that might get a little bit technical, but the idea is always toward understanding what's happening in that act of reading, right? It can be very surprising. And so then when you bring back to the clinical context, it's not that then we want people to be sitting in the exam room saying, well, this is what Gerard Jeanette would call a heterodiegetic narrator as opposed to a homodiegetic narrator. It's more that you're sitting in the exam room, if you're a clinician, and you understand that the patient who's relating her experience to you, it's not just the content of what she's saying, extracting the data and sticking it into the electronic medical record. It's also,
oh, damn it.
You there?
Hello, this is Sydney. I'm back-end support here. I think we've lost Nina's stream for a second. Nina, if you can hear me, do you want to try popping in and out? Hello. Hi, Danielle.
Hello.
I think your talk was going great.
Oh, thank you. Yeah.
Hopefully we'll have Nina back in 1 second.
No worries. Well, while we're waiting for her, I'll hawk our book.
Oh, definitely.
Those of you who are interested in learning more about narrative medicine, me and my Columbia colleagues wrote this book called The Principles and Practice of Narrative Medicine from Oxford University Press. And it goes into more detail about all of these aspects of the field.
Very cool. All right, I'm not Nina, but I'm going to ask you just a question. Oh, she's back. Perfect.
Oh, so sorry. That was I'm loving this conversation so much, and I really want us to be able to use the audio for Raging Gracefully. So suddenly you were going out, and I think it was me. I think my internet died. So let's back up for a teeny second and just go back a little bit, if you don't mind, to where we were talking about Virginia Woolf and To the Lighthouse and the process of reading and kind of what you get out of that, because it's really interesting. And then I want to talk about reflective writing a little bit.
Yeah, no, so I was just saying that in reading Virginia Woolf or any other text very slowly and carefully, you're inculcating the skills of close reading. What is it that you pay attention to in reading the text beyond plot? And one of the reasons why Virginia Woolf is a great way to do that is because there isn't a lot of plot into the lighthouse. I mean, there's kind of like, are they going to make it to the lighthouse or not? Which you have to read the book to find out. What even then you don't really even find out. So when plot is kind of attenuated like that, then well, what else is there to pay attention to? Well, it turns out there's an enormous amount to pay attention to.
Yeah.
So the analogy to the clinical scenario is that the clinician is listening not just for plot, like, well, when did the pain start and what's the diagnosis, but also all the clues that the person might give in terms of thinking about how they tell their story. So if you say, well, what brought you in here today, Nina? Say I'm a clinician. Well, you're going to be making so many choices about how to tell your story. You're going to begin somewhere, presumably. You're going to include certain details. You're going to leave other things out. And if I'm an attentive and humble listener who's trying to understand what I can learn from the way you tell your story, then I'm going to learn a lot. And guess what? You're going to feel heard.
Yeah.
Exactly. Feel heard. You're actually going to be heard. And then you and I are going to have a much better bond and better trust.
Affects exactly everything.
Yeah.
And so it's interesting when you were saying that about where you decide to tell your story, because I remember the very first day in the program or during our orientation was the first time I ever did what became a staple of the program. And I assume it still is, but I don't know, where we do these reflective writing exercises. I remember sitting in a room at Columbia and Nellie handed out a poem and we were given a prompt, and the prompt was, what brought you here today? And of course, everyone answered it in a very, very different way. And so can you talk to us a little bit about the use of those writing prompts? Because actually now in the Wolfer community, I don't know if you know this, but we started it during COVID because we were all bored. On Sunday afternoons at 5 o'clock every week, I run a reflective writing session.
Oh, great.
And it's so fabulous. And, it's obviously something I used when I was in the program, and I used when I worked at the hospital with medical residents and with nurses and various people, but I hadn't done it regularly in a long time. And so now we have this core group. People come and go, but we have around 9 of us who show up every week. And it's such a gift, that exercise. You can just do it in so many contexts. So can you explain it a little bit?
Yeah, and I mean, this isn't, the kind of prompted writing is similar things are done in different practices. So, nothing's really completely new under the sun. But in a narrative medicine workshop, one way to do it, and it's not meant to be prescriptive, but like one way to do it is, let's say you bring a group together, say it's 9 people, so you have an hour and a half, and read something together, a poem, an excerpt from a novel, but something short, something you can read together and talk about it, start to unpack it, not just like, I liked it, I didn't like it, I like this character, I didn't like this character, but what's going on in the text, how is it creating that effect? Mm-hmm. So doing that a little bit, and then the prompt is something that gives people the opportunity to connect that kind of conversation with their own experience of it, but with trying to be very careful, especially in a situation where there's, it's like a work or school situation where you're not requiring people to, divulge intimate things about their lives, but people will kind of self-regulate if you give them the opportunity, but it's not required. So one example is we've often taught this story by Alice Munro called The Floating Bridge. I don't know if you remember it.
I do, yeah. She's amazing.
And you remember at the end of the story, the main character is standing on a floating bridge?
Yep.
And so in the discussion, we would talk about that, look at that scene and how it's described, and this floating bridge, which is a real thing in the story. And then the prompt that we sometimes use is, talk about a time you were on a floating bridge.
Mm.
And
That's a great prompt.
It's a great prompt because actually some people respond literally, just like with the prompt that you described, like what brought you here today. Some people are going to say, well, I took the prompt from us. Yeah.
Right. Some people, when you give that prompt, some people talk about the subway, other people talk about the day they were born, other people talk about, it's really fascinating.
Right. Well, my grandfather who died 30 years ago, blah, blah, blah. And with this one, you can interpret it that way, which is totally great. You get to learn about times when people were on a floating bridge. But many people talk about times in their lives or something they might be experiencing at the time that they're writing, when they feel like they're at some kind of pivot point in their lives. Mm-hmm. But then it's open to interpretation. So what's the bridge? What's the floating? What's the, and right. We only give, and I'm curious to hear how you do it with this group, but we often intentionally give a not very long time to write. We'll say, okay, you have 5 minutes to write.
I do.
And it's really, the surrealists used to do this, where they had this practice called automatic writing, it was designed to try to bridge to the unconscious, so that you're not processing too much. And this is somewhere in between, but people do often write things that they are very surprised by.
I mean, I have to say, I mean, I mean, I've been doing it for years through you guys, but it still really surprises me every week, A, how beautiful the writing is,
Yeah.
and B, how wildly people differently they interpret the prompt, and just how healing and moving it is. I mean, even that prompt right away, talk about a time you run a floating bridge, instantly takes me to some sort of transitional moment in my life. So what happens is the prompt just takes you somewhere. And I always say to people, I mean, again, all the things you guys taught me, like you can write in any form, you can write fiction, nonfiction, you can write a list, you can draw a picture. Um, it, but it's really, and it is so simple, and it's not, as you said, it's not reinventing the wheel. It's not limited to working with patients and clinicians. You can do it in any context. But the way I explain it is, because I always want to make sure people don't feel intimidated, like they don't have to come in and understand poetry or be able to analyze anything. It really is about using the text as a way to just access what's going on inside of you. It's like I mean, that's the simplest way for me to explain it.
Yeah. Yeah, absolutely.
Really interesting. So, so now are you finding that people in the narrative medicine program, do you feel like there are more like job prospects than there were 5 years ago?
There are some, it's still, I mean, and we try to, say this very clearly to everybody at the outset who's considering the program. It's still, if you have another career, you're planning to go into medicine, then that's going to be your primary career, but you can start to bring in narrative medicine to that. There are increasing opportunities. I mean, within academia, for example, like teaching positions at medical schools, at colleges and universities in different contexts, they are growing, not as quickly as some of us might like.
Yeah.
But for example, and this is just related, in undergraduate programs, colleges and universities, the number of majors and minors in health humanities, which sort of encompasses narrative medicine, and again, they can be called all kinds of different things. The program could be called literature, medicine, and society, or medical humanities, but they're kind of allied. Those programs are growing actually at an exponential rate.
That's great. That's really great. Yeah, I remember noticing that when I was coming to the end of my graduation and trying to figure out what to do. I mean, places like Penn, like there are all sorts of, Harvard, all sorts of places have programs. And I remember being really surprised. I can't remember if you went, but I went to that conference in England the summer I graduated.
Yes.
And it was really interesting how prevalent narrative medicine seemed to be in Europe, right? It seemed to be kind of also, and interestingly enough, the menopause world is also much further along in England than it is here. Like there's much more kind of frank talk and stuff about menopause. It's really interesting. Which is related, right? It's that idea of kind of talking about our physical experience.
Yeah.
Yeah. So, well, this is so interesting. And do you want to also tell us about your book before we finish up?
Well, it's funny you should ask, Nina, but I happen to have a dummy copy right here on the table.
Nice. Please tell us. It's such a great title.
Well, thank you. You might wonder what this means, which is a good question because I made it up.
Well, read the title out loud.
So it's called Metagnosis, Revelatory Narratives of Health and Identity. And it's supposed to be out this month, but there are so many pandemic vagaries. But it'll be out soon. And it's about, so I coined this term because there was nothing to describe it. It's about when people learn that they have some kind of condition, like a lifelong condition or a really long-standing condition that gets discovered through a variety of means, but they weren't aware of it before. So an example would be, so this can happen either just because the thing was never detected, which happens all the time, or it can happen because the diagnostic boundaries themselves have changed. And so there's a condition that's now recognized that wasn't before. So an example of that would be, I used to work with David Byrne, the musician, and he self-diagnosed with Asperger's syndrome years ago. He's never bothered to get a formal diagnosis as far as I know. But I mean, Asperger's syndrome didn't exist when he was a kid.
Right.
So that was a case where the diagnostic boundaries are changing. And in fact, it doesn't exist according to the DSM. Asperger's syndrome came in 2000, and then in 2013, it it was enveloped largely, but not entirely enveloped into autism spectrum disorders. So I'm interested in that experience that people have, and how do people integrate that information. And so that's what the book is about.
Super interesting. It reminds me, a good friend of mine had thyroid cancer about 10 or 12 years ago and had it treated and had surgery and was fine. And she just went to an endocrinologist a few weeks ago for a checkup, a new endocrinologist, and was told that she never had thyroid cancer, that the markers for what thyroid cancer is considered to be have now been changed, and she never should have been needed to be treated at all. So it's kind of the inverse of what you're talking about. But
how did she feel? How did she feel about that?
She feels really weird about it. I mean, she's been taking Synthrax or whatever that medicine is for all these years, and apparently didn't need to. I mean, she feels really frustrated and upset about it.
Right.
You know, but nice to hear that you didn't have cancer, I suppose.
Right. Maybe would have been nicer to know then, but yeah.
Yes, exactly. Yeah. So, is your book? Who's publishing it?
Oxford University Press. It's an academic title, but I think it's pretty accessible. And there's a chapter that's all about stories of people who've had this experience in different contexts. So from ADHD and autism spectrum disorders to I talk about my own experience. This happened to me, but it wasn't with one of those kind of conditions. It was with a cognitive visual impairment.
Mm-hmm. I remember this. I remember you wrote a beautiful essay somewhere years ago that I loved about this.
Oh, thank you. I think that would have been I published a piece on that in Creative Nonfiction.
Yes, it was great.
And that's actually what sparked my interest in the topic, because I remember at the time, thinking, this is really strange. The fact that it's this retrospective revelation is really unsettling. And this isn't really being addressed, because in a medical context, it's more like, okay, let's make the diagnosis.
What do we do now? Right.
Yeah. And in my case, it was like, everybody, the main thing was to make sure it wasn't, I didn't have any ongoing risk factors for, MS or a brain tumor or something, which thank God I didn't. Mm-hmm. And so, but then once that was ascertained, it was kind of like, great, go forth, go back to your life. And I was like, but wait a minute,
I'm marked.
So I got really curious, and I thought, well, it's one thing, vision is really, obviously it's an important part of one's life, but I thought, well, what if that happens and it's something that is really, really part of what you think of as being your identity? So you're told that, oh, the way that you think or the way you attend to things in the world is actually pathological. Mm-hmm. Well, okay, you might be relieved because it helps explain a lot of difficulties that you might have had. And people really do, they're carrying so much shame and guilt about, ADHD kind of stuff. And so that is for many of them, it is a profoundly cathartic kind of.
It's a relief in a certain way. Yeah. I have a friend whose son was recently diagnosed with Asperger's, and he's 12 or 13. And of course it was very upsetting, but it was also a relief because it was an explanation and it makes me think a little bit about infertility is something that is so profoundly shocking and disturbing. You walk around thinking you can have children and that's going to be your future. And then suddenly you're told that your body isn't working the way you expect it to. It's very surprising.
Yeah, that's a good example, because it's something where maybe you've had a condition your whole life, but you just didn't know. I mean, you didn't know about it until such time as it became apparent. And so it's kind of in a way, it's a non-event because nothing has materially changed, except of course it's an incredibly profound event for the person and their family when it happens.
Right.
Yeah. So how do you make, and this goes back to narrative medicine, which is, how do you make that into a explicable and understandable narrative? Because that's what you need to be able to understand it yourself and to share it with others.
Yeah, it's complete narrative medicine. Hopefully you're going to use the book in the program because it sounds like it should be. I mean, that's the whole idea, right? Is how do you tell your story? How does your story keep changing? How do you convey your story to yourself and to others? I mean, it's super interesting. I just love that I did that program and that you're doing all this work. It's so great. And so would you describe the book as memoir?
It's a hybrid. It's kind of like Maggie Nelson describes the Argonauts as auto theory, which is also a term, it's got a big chunk of that in it, because I do tell my own story. But then from that, weaving in other narratives and theories and kind of using that as a way to try to unpack, well, how is it that we use narrative to understand our experiences? I just pulled up the infertility quote. There's a beautiful quote from Rachel Cusk, the novelist.
I love her. I love her. I love Maggie Nelson, but I love Rachel Cusk. She's pretty much my favorite writer.
Well, this was I think it was a book review on a book about somebody's experience with infertility. But here's the quote: "One problem with the discourse of infertility is that it has at its core a non-event. How can a woman talk about or learn from what hasn't happened to her? The advent of IVF has brought more than new technologies and hope to that expressive impasse. It has made infertility experiential, an active state with its own narrative, its own sufferings, and hence one anticipates its own wisdom."
Yeah, that's great. She's amazing. She's so tough. She's so cool. All right. Well, I hope you'll send me your book. I'd love to read it. I'm really pleased for you. Yeah, I would really, really like to read it. I don't like reading anything in e-version, so I'm a little bit of a pain. I like actual galleys or books, but I can also order it. You said, when is it coming out?
Well, it's supposed to be out in about a week. Right now, there's sort of a glitch on Amazon where you can't even pre-order it, but that should be fixed any day now.
Okay. All right. So it's called Metagnosis and Strudel. Stop. Metagnosis by Danielle Spencer. That's Strudel, Muffin's successor. Danielle, this has been such a pleasure. I'm really, really grateful to you for spending the time. So we're going to say goodbye now to everyone, and but you and I should stay on and just catch up a little bit.
Okay.